Wonderful. Looks like numbers are ticking up, so let's get started. Thanks everyone so much for being here today. I'd like to welcome you to our second webinar in our series on charting a bold future for Canada's health workforce. And we're excited to be bringing you today, leaders in government, to complement our webinar in November with a group of thought leaders. My name is Victoria Wiebe, and I'm a Director of Strategy and Policy here at Santis Health. And I've spent my career working with healthcare organizations to solve complex challenges in healthcare, including most recently on health workforce. I'm joined today by my colleague, Marcel Saulnier, who is an associate with Santis Health and a former associate ADM in health policy at Health Canada, who will co-moderate today's discussion with me. Before we get started, I'd like to acknowledge that I'm joining you today from Toronto, and I acknowledge that the land I join you from is on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Wendat peoples, which is now home to many diverse First Nations, Inuit, and Métis people. Next slide, please. Thank you. Santis Health is a management consulting, government relations, and communications advisory firm, which exclusively services the health and life sciences sectors. And as part of that, we host discussions on pressing issues in healthcare through our webinars and podcasts based on the issues that are most top of mind for our clients. I would encourage you to reach out if you're interested in learning more about Santis's work. And on the next slide, I'll just share a little bit more about an overview of health human resources before we get going in today's discussion. Health human resources has been repeatedly identified as a priority challenge facing Canada's healthcare system. And these challenges have intensified in recent years as the COVID-19 pandemic has impacted the front lines of our healthcare system in real ways, perpetuating burnout, challenges in recruitment and retention, and ultimately impacting the care that is delivered on the ground. And on the next slide, when you unpeel these challenges, it becomes clear how complex they are, and that resolving them will require multifaceted effort across a number of domains that impact healthcare delivery. On the next slide, as I previously mentioned, we hosted our first webinar on health human resources with several thought leaders from across Canada's health system this past November to understand perspectives on what it will take to advance change for our health workforce. And the discussion was enriching and highlighted a number of important takeaways, including the need in our conversations to move beyond problem definition and starting to act towards advancing change today, the need to think broad and bold about who we implicate in solving this problem, with acknowledgement that every actor in our healthcare system has an important role to play. And finally, the need to really think differently in terms of what collaboration means in this path forward. And so to talk about these items and more, on the next slide, I'm delighted to introduce our panelists for today's discussion, Dr. Geneviève Moineau and Dr. Karima Velji, who are joining us from their roles at Health Canada and the Ontario Ministry of Health, respectively. I'll hand over to each of the panelists to introduce themselves, starting Dr. Moineau with yourself.
Thank you so much, Victoria, and thanks for the invitation to be here today. As mentioned, I am currently with Health Canada, but before that, and my training is as a pediatric emergency medicine physician, where I have privileges here in Ottawa at the Children's Hospital of Eastern Ontario. I'm also a professor in pediatrics and in emergency medicine at the University of Ottawa. I have had a long career engaged in medical education leadership at the University of Ottawa, and then subsequently at the Association of Faculties of Medicine of Canada, where I led accreditation of medical schools and continuing medical education in university settings, and then as president and CEO for the last 10 years. That tenure ended in June. I have since been elected as the vice president for the World Federation for Medical Education, and then started my position at Health Canada in August of this year. Thank you.
Thank you so much for being here. Dr. Velji, I will go to you next.
Thank you so much. I want to acknowledge the Indigenous lands that we sit in and work in, and a big believer of the fact that the lands have always been and will be the lands of the Indigenous people, and a collective commitment not only to the principles, but to the actions of truth and reconciliation. I'm so proud to be in the company of Geneviève. It's a wonderful background that she brings to this health human resource file at the federal level. Between her and Lee Chapman, federally, I think we are in fantastic, basically, hands. My own career has two components to it. The first half of my career was as a clinician, as a registered nurse, basically. And I ended that part of my career as a clinician scientist and nurse practitioner in cancer care. And then from there moved to administration, basically, and have been a VP of patient care and chief nurse in different academic health science centers in Ontario. And I would say the pivotal contribution I would say that I've pushed on is creating integrated models of care for the people we serve, co-designing those solutions with our citizens, basically, and then creating HHR solutions in those models where we push the boundaries, we push innovation to its maximum potential. So that's what brought me, that's why I was recruited into this inaugural role at the Ministry of Health. It's a new role, it's Chief of Nursing and Professional Practice, and the role has been placed at an Assistant Deputy Minister role for the first time in Ontario. So the role sits at senior management tables. There is a lot of ability to influence certainly the office itself, the ministry itself in the work we do, but also influence political decision-making on the right path, basically, on the HHR file. So the hope here is to bring that wisdom from years past to this wicked file called Health Human Resources, and to see if we can push the boundaries, leverage the crisis to create the very big innovative solutions that we need to create.
Thank you so much to both of you for being here today and for taking the time to introduce yourself. I'll now hand over to my colleague Marcel to introduce the format for today's discussion and the first pre-prepared questions.
Okay, thank you, Victoria. Hello, everybody. Great that you could join us today in such large numbers. I'd like to also extend my thanks to Dr. Moineau and Dr. Velji for participating in this session today. You are both incredibly accomplished individuals in both of the spheres of the lives that you've lived outside of government and now in government. So you bring, I think, a really well-rounded perspective to the conversation today. So we have 3 prepared questions, which we'll invite each of the 2 panelists to respond to. We're also inviting audience questions to be submitted through the Q&A function. So please start thinking about those questions and write them up so that when we get to that portion of the session, we'll be ready with a few questions to pose. So we'll start with 2 of the 3 prepared questions, and then we'll go to the Q&A to get some of the questions from the participants. And then as we approach the end of the hour, we'll go back to the last of the prepared questions and invite the panelists to respond. And our objective is going to be to finish the webinar at the top of the hour. So we'll do our best to make that happen. So let's just jump right into the questions then. The first question I'd like to ask to Dr. Moineau and Dr. Velji is as follows. From your vantage points within Health Canada and the Ontario Ministry of Health, respectively, what is your vision for change as it relates to Canada's health workforce? And I'd like to start with Dr. Moineau.
Merci beaucoup, Marcel. So a great place to start. And again, as a reminder, from the perspective of the federal government, our Canada Health Act clearly indicates that a major role that we have is providing the financial support to the provinces and territories to actually deliver the healthcare for their populations. We also have a central role in providing overall support for other groups, but really I see us as a convener, as a central group to help bring all of the important jurisdictions together and to bring many stakeholders together to help move towards better health for all. And I'm very pleased that in the fall of 2023, the federal, provincial, and territorial ministers of health agreed to a renewed commitment on health human resource, and specifically related to 5 areas. The first on retention, where there's been the creation of a nursing retention toolkit. And this is really to try to address the very real and urgent issue of burnout within our health workforce, and to really ensure that health workers are in a much improved state of wellness, in better working environments, so they can stay in their jobs. The second area is domestic supply, and here we are specifically wanting to look at what Canada and provinces and territories need to do to enhance that supply, with a very specific focus as well on increasing the opportunities for Indigenous peoples, so that we can meet the ongoing and newly developed needs of our populations. We are focused on foreign credential recognition and ethical recruitment. And here again, some work being done with regulators on the way that we can expedite the licensing and the credentialing of individuals who want to come to work in Canada, and to do so in an ethical way. The next one is labor mobility, and really wanting to, beginning with physicians and nurses, look at how we can improve the flexibility of that mobility across the country. And finally, related to health workforce data and planning, we know that we need to really enhance the data that is available to us, and how we use that data for future planning.
Okay, thank you, Dr. Moineau. That's excellent overview of what the vision is at the federal level, and we'll come back to where things are at in the progress on those various initiatives that you mentioned. Dr. Velji, would you like to weigh in on this one?
The question is a question of vision for health human resources, and just to understand jurisdictionally, first of all, applauding the work the federal government's doing in the area of HHR, but jurisdictionally, the provincial territorial governments have the business of delivering healthcare to their population, and you cannot deliver that healthcare if you don't have the health human resources to deliver. It's mostly an HHR enterprise, basically, the healthcare delivery. So on that end, certainly from a vision perspective, I would say never should we find ourselves in the situation that we find ourselves in today. We predicted the shortages before the pandemic, that hit before the pandemic 15 years ago. And very little was done, not just in our country, but across the world. We were blind to the actions. We didn't move to action fast enough on HHR. The looming shortages were staring at us, but the action was not there. So we found ourselves predictably. We ended up with the shortages we had predicted 15 years ago. But then, of course, the pandemic blew it all open because the whole workforce expectation changed. So certainly the foremost thing I would say in the vision is never find ourselves in the urgent situation that we have found ourselves today. Have a better, more long-term oversight, or basically over this issue. However, never miss the opportunity that comes about in an urgent situation or in a crisis. So in Ontario, I am pushing this. We are going to leverage the crisis at hand and push the stuff we haven't been able to push in the past. So all the scope of practice changes, I'll speak to you. There are 4 pillars in our HHR strategy, and we are pushing innovation in all of those 4 pillars, taking advantage of the urgency basically at hand. Because a crisis requires a crisis response. You cannot say on one side of our mouth, it's a crisis, it's an urgent situation, and then our proposed solutions will be years in the making. We need them today. So there's an urgency to the vision, basically. Second part of the vision would be a forecasting approach where you tie the HHR planning with the health planning. So you don't plan for increasing hospital beds or long-term care beds or primary care capacity without an HHR plan tied to that capacity plan. So I'm very pleased to say in Ontario, we finally have a 10-year, a long-term forecast plan, not only for healthcare, but associated with that now an HHR plan that looks at 10 years into the future, which is unknown in the world of HHR, that you can do this long-term forecasting and planning. The third one is growing our own workforce to the point Geneviève makes around ethical recruitment. We are Canada. We are Canada. For us to close our gaps on HHR, our vision should be mostly growing our own domestic workforce and retaining the people we have, but also removing the barriers from people who have voluntarily chosen to come to Canada to be a nurse, a physician, a PSW. So we must remove those barriers away. And I'll speak to that when we come to our strategy. But let's not steal HHR from other countries because they have their own HHR dilemmas. And the last thing I would say is proper deployment of our workforce, that in our vision, we should have a happy, healthy, thriving workforce, people who want to work in healthcare, delivering beautiful care to people. And that happens today. We've just become invisible to the great work that's happening by our health human resources today, but that we've deployed them properly and equitably across our country so that we don't have the haves and the have-nots. So from a vision perspective, that, and the last thing I'll say is push the foot to the pedal faster. We need solutions yesterday. It's the urgency to create innovative solutions has to be put on steroids. It's missing. Largely speaking, we get stuck in the ways we know how to do stuff today, and that opportunity for change, we need to grab those opportunities faster. So never do we hesitate in Ontario to say we will be the first movers, we will take a risk, we will learn from the risk we will take. And I'll give you a couple of examples in later discussion on some things we are trialing to try and lead the conversation in the country, basically.
Okay, thank you, Dr. Velji. That's a great articulation of a vision for Ontario, and thank you, Dr. Moineau, for expanding on sort of the national picture of what the priorities are in for the health workforce. So now we're gonna dig in a little bit deeper on both levels, maybe starting with Ontario this time, just to get a better sense of what you're working on right now, like really practically. Dr. Velji, you mentioned like it's important to do stuff that will make a difference now, not just in a few years or 5 or 10 years. And so I'll just turn to each of you and then ask you to comment a little bit more and give a few examples that you think are salient about things that can be done right now, things that are perhaps bold to move the yardstick forward. So let's start with Dr. Velji.
So we have a strategy, a health human strategy in Ontario. So we've reasoned about the multiple tactics that we used to have, and we've created a strategic plan or an approach. It has 4 pillars. The 4 pillars are education expansion. Second, scope of practice expansion of practitioners. 3, expedited pathways for interjurisdictional and international practitioners. And 4th is retention and distribution of the workforce. So quickly touching on each. Education expansion. The whole name of the game is creating more HHR capacity. That path starts in education, as you can imagine. So we have a historical expansion underway, the largest in the country. In fact, sometimes I feel the largest actually comparatively to many parts of the world. We have a medical education expansion where we've added 260 undergraduate net new seats in the system and 449 postgraduate seats, 60% of which are geared towards creating physicians in the primary care space. For nursing, we've added 3,000 net new nursing seats in the system. Just the expansion alone will add 8,000 nurses in 2 to 3 years from now in the system. So a big nursing education expansion. We've also had a very big PSW expansion. And then we have expansion on the nurse practitioner side. We've doubled the number of NP seats in the province of Ontario. And we have a physician assistant expansion as well. So a big expansion education-wise. And we are starting to now push compression of education programs to see what the art of the possible is to create a nurse faster in the system. So can we take a baccalaureate program and go from 4 to 3 years, for example? So we're starting to push on those points. And we have many first mover education schools who are already showcasing basically these innovations, because the whole issue is how to create that HHR capacity of good quality, but faster in the system and not compromising education standards. Equivalently, we've put a lot of support in the clinical areas to support those clinical education endeavors with preceptor support, mentor support, so on and so forth. In the scope of practice pillar, our biggest scope of practice expansions are in the direction of pharmacy, nursing, and paramedics. So you've seen finally in Ontario, we were stragglers. We finally caught up with the many other provinces in implementing minor ailments for pharmacy. Pharmacists being able to assess and prescribe for certain minor ailments. We are at 19 minor ailments now, and our objective is to double that number in a very short period of time and move to the good practices of Alberta, Saskatchewan, and other provinces. We finally implemented RN prescribing in Ontario. Again, we were stragglers, but we've leveraged the crisis and we've pushed that file forward, basically. So starting now, January 2024, RN prescribing will be alive in Ontario. Many other scope of practice changes on the nursing front. We've further removed nurse practitioner barriers, scope of practice barriers away from nurse practitioners as well. This extends the current workforce and improves their satisfaction in the work that they do. And then in the area of paramedics, a lot of work in the area of community paramedicine, increasing their scope, particularly supporting people to not go to hospitals if they don't need to, supporting them and stabilizing them in the home setting. And then we've touched midwifery scope of practice, many other scopes of practice, but I won't get into all the details. The third area is expediting pathways. I'm very proud to say that we have removed a lot of barriers for people, international practitioners who are already nurses, who are already physicians, who have been educated internationally, who've come to Ontario on their own. We haven't stolen them, but we had barriers in our regulatory colleges and other processes where it would take us an average of 2 to 3 years to register them. We have significantly reduced registration time for those international practitioners without stealing them, so working within the WHO Code of Ethics. And I'll tell you, our numbers speak for themselves, which I'll speak to in a second. And we are the only province that have implemented what we call as of right legislation, which means if you're a nurse in good standing or a physician in good standing anywhere else in Canada, and you're registered, say, in Manitoba, we won't come and steal you from Manitoba. If you choose to come to Ontario, you can start to work in Ontario. So we recognize other provinces or territorial jurisdictional licenses. Basically, I'm hoping moving us to a national licensure approach for selected professions. And then lastly, we have our retention and distribution bucket. We have a lot of initiatives there about incenting people to work in the right places, distributing our workforce properly in Ontario, but I'll be the first to say we have to do much more work in the area of retention And the toolkit that Lee and Geneviève and others have spearheaded, I think will serve us well in the provinces and territories. So more work to be doing, better work in the area of retention. Last thing I'll say, our metrics speak for themselves. Our strategy is working. We have had a historical registration of new nurses in the province for the last 2 years. We had 15,000 nurses register new in 2022, 17,400 in 2023, half of whom are international nurses who were stuck in the pathway, for whom we've removed barriers. So our numbers speak for themselves. They are heading in the right direction. You wouldn't know that if you just were listening to the rhetoric in the media, because the rhetoric is always the sky is falling, but I'm follow the data. And that data indicates we are making good strides, and our attrition from the profession, say for nursing, is has increased slightly. So it has increased from 1% to 1.8%. People are not leaving the profession in droves, people. We have to put some of those rhetorics aside and follow the facts. So people don't leave the profession, they leave workplaces. They move from hospitals to public health. They move from long-term care to agencies. There's a lot of movement of people, but they're not leaving the profession, nor are they escaping to other countries.
That's certainly good news, and great to hear some of that myth busting there from Dr. Velji, and I think quite an impressive array of actions that have been taken over the last couple of years and that are playing out, and hopefully we'll get to see a bit more in the public's domain some of the indications and the data points that you're seeing as indications of progress. So looking forward to hearing more about that. Dr. Moineau, so you were at the federal level. The feds don't have all of the levers that the provinces have in this space, but you do have some. And of course, you have the statement that was issued after the last health ministers meeting last fall with the points of action that you detailed in your first response. So where are we at in terms of the progress on those initiatives? Can you give us a bit more of a granular view there?
Yeah, absolutely, Marcel. And again, I also want to recognize the incredible work that Karima and Ontario are doing to really address the issues head on and with great courage. So you've heard from a retention perspective about the nursing retention toolkit. It is just about ready for prime time. It's just getting buffed up and making sure the translation is correct, et cetera, et cetera. So look out for that in the next few weeks. Again, this has been done in collaboration with so many nursing leaders and employers. I know Karima was engaged in this, and really, again, led by Lee Chapman, our Chief Nursing Officer at Health Canada, and really excited about that, and really thinking that this is going to be helping employers and all those who need it. From the domestic education piece, the study that was mentioned in the statement in the fall has now been officially launched by the Conference of Deputy Ministers just a few days ago. We have the official terms of reference for the study, and really excited that this is going to be, first of all, as I mentioned, the aspect of the Indigenous health workforce will be done with Indigenous leadership, and we need to do that in a good way, understanding that the specific needs need to be addressed. We are going to be focusing this study on the needs as well in rural and remote communities, which we know, although there's some work being done, there's nowhere near enough work being done, and we need to determine what are the best ways moving forward there. And we will be focusing on professions that are engaged in primary care. So that is family physicians, all 4 categories of nurses, pharmacists, physios, and OTs as a starting point. And we are going to be not only gathering data from all the appropriate stakeholders, of course, all the jurisdictions. We will be looking at a 5 to 10 year perspective, looking at the current status, the recent announcements, as Karima mentioned, in the different jurisdictions, to understand what we know about the future. And then looking at what the needs will be in the future. So not just about, we will be using, of course, CIHI will be a partner here, and using CIHI data for those professions. And yes, for example, for physicians, we have some good documentation about services provided, but we will only be doing justice to this work if we try to best assess the actual needs, because there are so many unmet needs, or individuals who perhaps are attached to services but feel that they're insufficient. And so we really need to try to grapple with that. And we know that we are being asked to produce something that will be able to put before the ministers next fall. That will be a first step. And knowing that this is work that will need to continue, they'll need to be expanded, and really excited about that piece. Mentioned that we are looking at ensuring that there's a 90-day service standard for licensing, and this is so at the level of the health regulators. So this is, of course, once there has been document verification and all immigration issues are managed, that an individual shouldn't have to wait longer than 90 days for that processing. And from an ethical recruitment perspective, as Karima mentioned, this is so important. We are taking the World Health Organization ethical recruitment framework, making sure we bring it into the Canadian context, and again, in collaboration with all of the appropriate jurisdictions and stakeholders. Again, we'll be bringing that to the ministers for their support and approval in the fall. With regard to labor mobility, we're starting with physicians. As many of you will know, there's an Atlantic registry that currently is in place. We are in the process of evaluating that to see what the lessons learned are as we move towards a more pan-Canadian approach. And again, Karima mentioned in Ontario, the as of right legislation, which is unique. And again, another opportunity to see what can be done across the country. And then next steps will be addressing this in nursing, and those conversations have just started. And finally, many of you will have heard that in December, we announced that there's a new entity called Health Workforce Canada that is going to be the place where health workforce data will come alive. We are working again with CIHI and with the jurisdictions and all the other stakeholders in health workforce data and planning. And this new organization really will take the data, help with the analysis, help with the access to the data, and put that together with innovative activities across the country, so that we can actually create a really strong network where we are informing and sharing and proposing opportunities for change to really help inform the policy and decision makers. So really excited about that new announcement as well. Back to you, Marcel.
Okay, thanks. And maybe just a quick question, just to clarify. So is that last piece Health Workforce Canada, and the second piece that you referred to, the study of, are those two connected? Is Health Workforce Canada playing a role in that study, or?
It's like, I couldn't have asked for a better follow-up question. Absolutely. So the work that we're doing with the study is really seen as a first phase. And as Health Workforce Canada becomes established and becomes a little bit more robust, we will be handing that work over to Health Workforce Canada, we presume this fall, to continue the work. So yes, the current interim CEO of Health Workforce Canada, is part of the team, the project team for our study. And that will be handed over in the fall. And again, we will all continue to be involved, but it's just sort of where it will be, where the driving force will come from. But it's almost like you understand how it works in government, Marcel.
Still a bit rusty, but I remember a few things from a few years back. Okay, so this is a super start. I think we can now move over to the audience questions, and I'll hand it back to Victoria to manage that portion of the conversation. Over to you.
Thanks very much to the three of you for getting us started, and thanks to all who are participating today for sending in some really interesting questions. I'll hopefully start with a softball, which is a request for more information. Dr. Moineau, for yourself on the minister study, and Dr. Velji, for yourself on where folks can go to learn more about the HHR capacity plan. So perhaps Dr. Moineau, to you first.
Yes, so again, the study and the information that I just shared with you is just hot off the press. We literally had the meeting of the Conference of Deputy Ministers last week. And if you are someone who thinks that you would like to have things to say, or would like to have a conversation with me about that, I'm very happy to share my email address so that we can follow up together after the webinar. And so, Victoria, I'm not sure how the best way to do that, but I'm very happy to do that.
Thank you very much.
For the healthcare capacity plan, I'm so proud of this work, because it's a very non-traditional capacity plan. There are two or three unique features about it. So one is, it doesn't just forecast demand and supply issues. It doesn't just say you need 10,000 more hospital beds 10 years from now. It tells you how to bend the demand and the supply curve using 25 capacity strategies, basically, that go across a hospital care, primary care, home and community, and then HHR. The other thing is, the HHR plan is ingrained into this capacity plan, making the point that a long-term care bed is not a capacity unless it's staffed. So you must put HHR as a very significant component of a capacity plan. And rarely do capacity plans do that. So public communications on our capacity plan have not occurred yet. There is no anticipated timing yet on it. Government needs to make that decision, because there is a second product we are marching to cabinet in short order on this plan. However, quietly, if you want to converse about the plan or understand what the work that we've done, I think our division, you can just knock on my door and I can give you a glimpse on what the plan contains, the methodology we've used, and the strategies that are in the plan. The overall conclusion, by the way, is if you want to bend the supply and demand curve, your focus has to be scaled investments in primary care and home and community care. We cannot bend the curves in any other way. We have to focus on those two sectors deeply. We have to fix primary care to fix healthcare.
Thank you very much. I'll go to the next question, which has been asked in different ways several times in the Q&A, related to strategies that are being undertaken both at the provincial and federal level related to the broad health workforce. So I'll include in that the unregulated workforce, the broader workforce that includes mental health workers, college-trained and community health sectors. It's a broad question, but would love to hear what is happening at the provincial and federal level related to those. Perhaps Dr. Velji, with you first.
Our capacity plan tackles that heads on, because when you do the forecasting of what the needs of your population will be, the growth of the population, the demographic shift that's occurring, and then against that, map out what are the health capacity considerations and the HHR considerations, you come to this place where you say, oh my God, The biggest gaps are in home and community and in primary care. And to fix that gap, no amount of physician and nursing work alone is going to fix it. You must focus on your PSW workforce as an example. So our plan really envision, it's going to push on the point of the unregulated care providers because we create them faster, as you can understand, in the system, and we need a lot of them to care for people in their homes. So there is a big PSW strategy that has been envisioned, and it's already in action. We've created 25,000 new PSWs in the past year in Ontario. But guess what? We lose 25% of everything we create every year on PSWs. There's a big retention issue. So there's a big retention mechanism needed, a compensation conversation that should occur because it's a racialized, mostly gendered female workforce. So there's a lot of gender politics and issues to consider on this workforce. So we are dealing with the issues of compensation, wage harmonization, a career laddering for these women, mostly women, workforce. There is a PSW strategy, basically, that we have started to action, but there is much more work that needs to be done. And then in every other profession, we are pushing the question of extenders. And I'll give you midwives as an example. If you look at the state of obstetrical care in the North and in the Indigenous communities, we should be ashamed. That should not be how care should be in Canada. It's one of the most abysmal things that we do from a Canadian perspective. And yet there are models in care within our own country. For example, in Quebec, and there are models in countries I have been to as a volunteer. I do a voluntary work in international countries. There are beautiful midwifery extender programs in Afghanistan that we could learn from, where Indigenous Afghani women deliver normal vaginal births in their own communities. We don't unearth people from their own communities for the sake of childbirth. But we do this in Canada, in Indigenous communities. We fly women, we unearth them and take them into a foreign place so they can deliver their babies without any cultural context and support around them. And midwifery extenders play a beautiful role, doulas and other roles in other jurisdictions. We need to embrace that because there's no number of nurses or physicians or the traditional HHR alone that's going to solve the dilemmas of tomorrow. We will need to embrace innovative roles and models.
So much, Dr. Moineau.
Yes, no, I just want to support everything that Karima has just said, and add, totally agree that, for example, PSWs are that, they are the soul of the system because they are the ones who just do the most difficult care day in and day out, and amazing. The challenge we have is that we can't, in many jurisdictions, we can't even identify how many people are involved in that care. We can't measure. And so it's hard to plan around groups that you can't measure. And so, that's one of the only reasons why, PSWs were not in our original study, because we don't have the numbers. And that, I think, is going to be something that Canada really needs to grapple with our PT colleagues as to how do we do that. And again, looking internationally, there are some countries where, somehow they've mandated that every employer has to actually provide data to government about their workforce. Imagine that. So I'll just leave with that bold idea.
Thanks for that. And
I just wanted to say, what a great point. This line of sight, an invisible workforce, if you will, the majority of the people delivering care in Ontario, in fact, are PSWs, and they are the most invisible workforce. Yeah. Probably deliberately, one might say sometimes, because of how they are gendered or their backgrounds or whatever the issues are. we are about to stand up in Ontario a PSW oversight authority. That authority will be like a light regulatory college that will start to register individuals. And for the first time in our province, hopefully, we will start to create a line of sight into this workforce. And I can't wait.
That's wonderful. Thanks to both of you for sharing those, and certainly agree that the data piece is a really important question to solve. I'll ask a follow-up related to this. A lot of the conversation that we had in November with our thought leaders focused on using team-based care as a model to incentivize rapid experimentation in models of care and improvement in the type of work that is done, scope of practice considerations, as well as accessibility of care to those on the front line. So I'm wondering what your thoughts are as it relates to current initiatives on new models of care, both at the provincial and federal levels.
Well, I can start quickly and then pass it on to Karima, because again, this really is work that is being done at the level of the PTs, but certainly at the federal level. Totally support the concept of teams providing care, however you want to call it, and that really the ability to enable each care provider to practice at top of scope. And so, and again, for those who don't like the terminology around scope or task, it's really at the level of their competencies. And so that should always be the goal. And I'm going to pass it over to Karima to tell us how Ontario is going to fix that.
I have a personal passion for this because I've worked in areas like rehab, mental health and addictions, where we don't give just lip service to teamwork. It's very good team models where it all starts with understanding the goals of the person you're serving. And then the right group of people stand up and help the person achieve those goals. So the core design, the teamwork is at a very different level of sophistication in some of our areas of specialty and practice. And I've had the privilege of witnessing them. It's emancipation when you see those areas of practice. It's exactly as Geneviève says, it's people working together to serve the goals of the person they are serving, but rising to the goal. So if it's a function-related goal, the physiotherapist can be the lead of leading the care plan on that goal. If it's a pharmacological goal, it can be a pharmacist who leads the charge on it. If it's a complex medical issue, it's a physician who leads the charge on that issue. And if it's a lot of responses to illness, a nurse can lead the charge on that issue. So it's really understanding our competencies and playing them out, not only to the top of scope of license, but beyond the top of scope of license, basically, to see how we can push it even over the edge. And what shall I say? Get over it is what I would say. People who resist it, teamwork. The time for that is over. The time for resistance is over. The name of the game is team-based models. Our whole primary care strategy is moving in the direction of team-based care, and our physicians want that. They want teams supporting their work, because the time for the lone wolf trying to support a whole cadre of people rostered to them, it just cannot be done in the way we've done it in the past. So, turn the page is what I would say. If you're stuck in the past, turn the page and move to the future of team-based care. It's here. It's here. All our primary care expressions of interest. We've recently sought proposals from the field. It's all going to favor team-based models of care.
Thanks very much. Perhaps in the interest of time, I'll choose one more question in follow-up to the conversation we've been having about team-based care and maximizing use of the broad health workforce. And perhaps, Dr. Moineau, I'll go to you first for this question, given your previous role. which is, what is the role of education in addressing some of the health workforce challenges that we are seeing across Canada, particularly as it relates to some of the professions that have historically been overlooked as part of this discussion?
Well, thanks for the question. I think it starts with education. And I think, as Karima stated earlier, we are a well-resourced country. Canada should be able to train its own health workforce in a better way than it is currently. Again, this is something that requires a lot of resource. As Karima mentioned, though, right? So some professions require more resourcing than others, and is not as much of a strain. But we really do need to increase our capacity in Canada. I think, as also was mentioned, we need to think differently about how we educate, and I think we've been stuck. And I'm saying this as a medical educator, we have been stuck in the way that we have been training, and I have more expertise with physicians than others, but I think it's probably true across the board. Let's look at how we can be innovative in the way that we produce our health workforce. And this is an aspect of the study that we're doing that we will be initiating. And so again, if anyone is aware of innovation that they want to share, I'd be really happy to hear about it, because we're really trying to scan and identify those great innovations that are currently in place. So it's all about education.
And don't wait for government to lead the way all the time. There is innovation, grassroots innovation, that has to, and it's actually already taking shape. There are many, many things underway in Ontario where first movers have moved. There are schools who've already moved in the direction of compressing education programs, or who ask the questions, oh, why can't externship hours count as clinical education hours, so that we can compress the programs and create our HHR capacity faster? Why are we proposing to increase postgraduate curriculum from so many years, expanding the years to graduate primary care practitioners? Let's just think about that a little bit before we move in a direction that's not going to serve us well as a country. So I'm very, very proud of the folks on the ground who have to deliver care, who don't have a choice to turn. They can't say no to the patient who has come to their door. So that necessity has forced them to innovate, and they've moved. First movers. And I say, you know what? That's the person I'm going to bet my dollars on. That's the people to fuel and fund. And then we try and scale up what they have trialed in their own ecosystem. That becomes the scale-up opportunity for policy or funding in the province. And we've done a lot of that. Our extern program was birthed at Sunnybrook. They started that. They trialed it, they showed us the results of it, and we said, you know what? We want this adoption. Provincially, we'll scale it up. And even in the work we do with stakeholders, that's how we do it now. Because I'm finding when you bring stakeholders around the table and you create big table discussions, it's analysis, paralysis. Like we talk about the same things 30 years later. And we need an act of desperation here. We need to move fast. So we say, you know, who are the one or two stakeholders who are showing promise? That's who we'll start the collaboration with. It's bilateral, trilateral, just move, keep on moving. And show the art of the possible, and then scale it up. But don't try and perfect it before we implement it, because we'll paralyze otherwise. The population is growing at such a fast pace and aging. It calls at us now.
Thank you very much. In view of the final prepared question, I wanted to just turn it over to the Q&A, as there has been a question that has come up several times related to the role of unpaid and informal caregivers as part of the health workforce, and how that is being considered as part of the federal and provincial plans. That will be our final question before we wrap up for today. Perhaps Dr. Moineau, I can go to you first.
Yeah, just I'll be very brief considering the time, but this is a very important question. And again, we've talked about PSWs and as an example of such an important component of the workforce. But we know that so much care is provided by loved ones, and how we manage that and how we support that, I think, is a question that we actually need to spend more time on. And I'll just leave it at that, just with the time ticking. Karima?
Thank you.
It's one of the 25 capacity strategies in our capacity plan. The gap between supply and demand is now, it grows as the population grows and ages. So, and some of it will be covered using the strategies I mentioned, and a lot of the gap will not close. So in order to close that remaining gap, the use of informal caregivers, compensating them in a way we did during the pandemic, when we were using essential care partners and other strategies, it's nothing novel. We've done it when it suited us, and then we turn away from it. It's like virtual care. We turned it so high, and then we retreated from it. We have to re-embrace, I think, some of those innovations we were using when we were dealing with a peak of the pandemic.
Thanks very much for that, and a great reminder at that. I'll hand over back to Marcel just so that we can finish up the conversation and talk next steps.
Okay, thank you, Victoria. Thank you, Dr. Moineau and Dr. Velji, for an incredibly insightful conversation, I think. I mean, my takeaways are, that this is, yes, it's a wicked problem, but it's fixable. We probably shouldn't be here, but we are here. And so let's figure a way through this. The really critical role that planning has to play here is not a sexy thing, but it's so critically important. And it's great to hear that so much is underway to enable that to happen. Really taking a broad view of the workforce. It's not just doctors and nurses, it's the rest of the team. It's informal and unpaid caregivers. That's going to be part of the frame. And then leveraging the crisis and being bold is another takeaway that I'm hearing. And I really appreciate the granularity and the tangible examples that you've given us about work that is underway at the federal and provincial level. So thank you so much for your time and your generous answers this afternoon. Really, really appreciate that on behalf of everyone who's participating. So and just moving on to bring the session to a close, a quick reminder that there is a survey for webinar attendees to fill out. Really would appreciate you taking the time to do that. We will also be sending out the slides and recording subsequently after the session today, so you can go back to that. And also wanted to give a quick plug for an upcoming event. To mark Cervical Cancer Awareness Month in January, Santis is hosting another webinar around this time next week with experts from BD Canada, 19 to 0, the Canadian Partnership Against Cancer. And the objective there is to explore what it will take to make good on Canada's promise to eliminate cervical cancer within the next 2 decades. So not a really important conversation, very important topic, and hope that many of you will be able to join us for that. And so we'll send you out a link for that session in the follow-up email today, and you'll be able to register for that session. So I think that's about it. Victoria, anything from you before we close?
Just a big thank you again to Dr. Velji, Dr. Moineau, to both of you for being part of today's conversation, and for everybody who attended today. Our thanks to you. We hope to see you next time. Take care, everybody.
Merci.
Bye-bye.
Au revoir.